Hi everyone. I'll be speaking on review of cancer management guidelines. So when I was asked to speak about this topic, I felt that I should review the evidence in the last 10 years, that is from 2012 to 22. And I'm not going to speak on each and every aspect of cancer pain management, but critically look at the various published guidelines that are there and how that could be interpreted and applied to a clinical practice. So I did a scoping search of literature very recently on 12th of August 22. And when I looked at the scoping search for the last 10 years, there were 94 papers which looked at various cancer pain management guidelines. I'm not going to speak about all 94 papers, but the important ones which are going to be relevant. So, in the overview of my presentation today, I will speak about the pharmacotherapy for cancer pain management, the guidelines of that, the non pharmacological management, the interventional techniques, and what are the Indian guidelines that exist. And lastly, to look at what is the quality of the clinical practice guidelines and how are they implemented. So, if we start with the pharmacological management for cancer pain, so there are two papers, both published in 22. One is both are from Japanese Society for Palliative Medicine, and if we critically look at these guidelines, most of them were consensus-based recommendations and were not directly evidence-linked. However, they have done a good review of literature and they have come up with 19 recommendations for pharmacological management of cancer pain, 6 for opioid induced adverse effects, and 10 for the procedures, interventional procedures. The important ones, the more stronger recommendations were methadone as a drug of choice when there is refractory pain and when it is not responsive to other analgesics. Using fentanyl and buprenorphine both as intravenous and transdermal preparation in patients with severe kidney disease, and not to use morphine and codeine, and continuous administration of opioids in patients with severe pain. Another paper, which is more of an American paper, which came in 2021, recommended as a level 1 evidence, grade A, that opioids should be considered for all patients with moderate to severe cancer related pain, and a level 2 evidence for methadone when other opioids were ineffective, which is very similar to what I have mentioned earlier, and ketamine as a drug when there is refractory pain. It could be either neuropathic, bone pain, or mucositis related pain. I also looked at the 2018 ESMO guidelines, and I have used only those recommendations which were level 1 evidence, and maybe one or two which is level 2. The using WHO analgesic step ladder, which is the commonly used step ladder, was a level 2 evidence. Opioids as a first choice, which I mentioned earlier, for moderate to severe cancer pain. Laxatives is a must for opioid induced constipation and should be routinely prescribed. We should use immediate release opioids for breakthrough pain. Transmucosal preparations are much better, like transmucosal fentanyl for breakthrough pain. And neuropathic pain, patients with cancer associated neuropathic pain could receive a tricyclic or an anticonvulsant like gabapentin, pregabalin, or a tricyclics. Now, breakthrough pain, when we looked at the guidelines from 2022, there was significant variability and discrepancy among the various published guidelines. So there was no consistent definition or consistent management plan that existed for breakthrough pain. There was a paper which looked at very site specific pain management in prostate cancer. And one of the important finding was continuous intravenous lidocaine was effective in managing post-operative pain, which is a very novel finding and probably should be looked at in other post-operative pains in cancer. and a bilateral transverse abdominis plane block performed at the end of the surgery lowered the pain score. So these are two important things for prostate cancer post-surgical pain. Now, looking at from pharmacological to non-pharmacological acupuncture for cancer pain, this is the only one guideline that I could find, which was a more robust guidelines among the various ones. The acupuncture had a very weak recommendation in terms of reducing pain intensity or decreasing the opioid dose or alleviating the opioid related side effect. There were few papers on interventional pain management and the guidelines, and one from 2021 publication, which had a very strong recommendation for using celiac plexus block for all pancreatic cancer related pain, using splanchnic neurolysis for the pain associated with the body and tail of pancreas, the superior hypogastric plexus, which was a level 2 evidence for intractable pelvic cancer, and it was only level 3 for ganglion impar block for perineal pains. Now, another intervention that what we commonly use for cancer pain management is intrathecal drug delivery. And for patients with intractable pain, not responding to opioids or having severe side effects, it is a level 1 evidence. Now, spinal cord stimulation was a level 2 evidence for refractory cancer pain. And using vertebral augmentation, like putting a bone cement for a compression fracture, in spinal metastasis was a level 1 evidence, whereas in percutaneous radiofrequency ablation, with or without augmentation, was a level 2 evidence. Now, if we look at the RFA, the radiofrequency ablation for dorsal root ganglion, was also a level 1 evidence. Cordotomy for an uncontrolled pain was a level 2 evidence. And using peripheral nerve blocks, either through using steroids or alcohol or an RFA, was a level 2 evidence as an interventional pain management technique. And all neurosurgical procedures, which was from the 2021 paper, like rhizotomy, cordotomy, and other neurosurgical procedures, were all level 3 evidence for cancer pain management. And if we look at among the cancer survivors, what is better? A 2016 paper published in JCO advised using non-opioid analgesics and adjuvant analgesics over opioid analgesics, and opioids to be used sparingly in a very select few patients. Were there guidelines from India? Yes, there were 7 guidelines from India, all published in 2020, and all prepared by the Indian Society for Study of Pain. And these are the references, and these guidelines focused on assessment of pain, diagnosis, pharmacological management, complementary therapies, interventional techniques, and in using pain in pain management in palliative and end of life setting. The big drawback of these guidelines was these were all the opinions of authors. The guideline formulation recommendations were not followed, and although it was evidence linked, the way it has to be linked with evidence was missing. So its real life applicability or practice applicability is still questionable. Now, what was the quality of these clinical practice guidelines that we have? There were wide fluctuation in the methodological quality of these guidelines. The reporting quality across study was poor. And also what we call it as fidelity to intervention. That means that if you want to implement an intervention, you need to follow that intervention exactly. That means if there is a drug regime or an intervention technique, it has to be followed exactly. The fidelity to intervention were very poor. So there were varying differences in outcomes between the studies. And even when we looked at the NCCN, there's a 2022 paper and adherence to guidelines. The adherence to guideline was very poor in adult cancer patients, and that's why probably the pain management still remained poor in a cancer setting. So in conclusion, there were few pharmacological and therapeutic interventions from the guidelines have very strong evidence for each. But overall, the most of the guidelines had very poor methodological quality and reporting quality. There is a lot of disparity in terms of recommendations from guidelines to guidelines, which only reflects the personal. These guidelines are prepared more of a personal opinion rather than research evidence being linked in guideline preparation. And as I mentioned earlier, low fidelity to the intervention. That means that not following a regime or an intervention exactly has a very varying outcomes. Thank you so much.